So today we are about to see how to examine a GAT case and how to take history of a GAT case in your final exams, for your final exams. So can we start?
Sure. My patient's name is Sri Kumar. He's a 60-year-old ex-serviceman hailing from Ernakulam. Date of admission is 1st February 2023. The presenting complaints were abdominal distension for 1 month duration, lower limb swelling for 1 month duration, yellowish discoloration of the eyes for 1 month duration. History of present complaints. Patient was apparently asymptomatic 1 month ago when he presented with abdominal distension, lower limb swelling, yellowish discoloration of the eyes, all for 1 month duration. The abdominal distension was acute in onset, gradually progressive in nature, not associated with abdominal pain. There was no history of chest pain or any breathlessness. The lower limb swelling was also acute in onset, gradually progressive and extended up till the knee. The yellowish discoloration of the eyes was not associated with clay-colored stools or high-colored urine. No history of itchiness of the skin or vomiting blood or any dark-colored stools. There was no loss of appetite or loss of weight. There was no history of any drug intake or any indigenous medications. There was no reversal in sleep pattern or constipation or loss of consciousness, etc.
Okay, so that summarizes the GI history of this particular patient, Mr. Sri Kumar. So whenever you are getting a GI case, what you need to do is that you need to start with a thorough history. So in your exam, most probably the examiner will ask you to discuss the history. So once the examiner is asking you to discuss the history, then you have to start with the predominant presenting complaint, in this case, which is a progressive abdominal distension. So first you can tell that as the patient had progressive abdominal distension, I will think of conditions which can cause progressive abdominal distension like fluid, fecus, fat, fetus. So in this particular case, it is more likely to be a fluid because there is a progressive abdominal distension and it is associated with pedal edema. So you can think that in this particular case, you are more tend to think, because it was a generalized diffuse progressive abdominal distension, you are more likely to think in terms of an ascites. And once you zero down into the ascites, then you always have to figure out what is the associated symptom with which the patient presented. In this particular case, the patient had yellowish discoloration of sclera. So ascites with yellowish discoloration of sclera means, so more often than not, what we need to find is that obviously there could be two different etiology for two different symptoms, but that is not how we will analyze a case. So why are we analyzing the history? We are analyzing the history to try to figure out if there could be one particular etiology, one particular etiopathogenesis or localization, which could explain both the symptom. Or in this particular case, pedal edema is also there. So all the three symptoms which you can localize. If you can localize like that, then that should be your first primary differential. So in this condition, there is a progressive abdominal distension along with yellowish discoloration of the sclera. So whenever you are getting an yellowish discoloration of sclera, then the next question you need to know is that whether it is just an isolated yellowish discoloration of sclera or if there is yellowish discoloration of urine and any clay-colored stools as well. So you rightly told. What you were told?
There was no history of clay-colored stools, any alteration in the color of the urine, neither was there any clay-colored stools.
Okay, good. So if there is yellowish discoloration of sclera without associated yellowish discoloration of urine, then definitely one thing you need to consider is indirect hyperbilirubinemia or prehepatic jaundice, because jaundice can be primary yellowish discoloration of sclera. Okay, although there could be carotenemia and other causes for yellowish discoloration of sclera, but for all practical purposes, if we are hearing a yellowish discoloration of sclera, especially in the setting of progressive abdominal distension, by default it is a jaundice. And if that is the condition, then you have to always ask for the history of yellowish discoloration of urine. If it is there, then that indicates it is a direct hyperbilirubinemia. And if there is no yellowish discoloration of urine, then that indicates the hyperbilirubinemia might be indirect hyperbilirubinemia. So in case of indirect hyperbilirubinemia, what happens is that the indirect bilirubin is bound to the albumin. So since it is bound to the albumin, it will not pass via the urine. So if it is echoloric jaundice is there, but the urine is not colored, then you have to think of, at least rule out a prehepatic jaundice. That is the first predicament. And if there is yellowish discoloration of sclera along with yellowish discoloration of urine, then either it has to be hepatic jaundice or it has to be post-hepatic jaundice. If the jaundice is very deep, then you have to think in more in terms of post-hepatic jaundice. And if the jaundice is kind of moderate and there is high colored urine, then you have to think in more in terms of hepatic jaundice. But if it is a post-hepatic jaundice, what happens is that there will be obstruction in the post-hepatic system. The bilirubin, the direct bilirubin, even when the liver excretes the direct bilirubin, because of the post-hepatic obstruction, it will not reach the GI tract, and there will not be any stercobilin formation which imparts color to the stool. So you are going to get a pale colored stool. So if you are getting a pale colored stool or clay colored stool along with high colored sclera, then you have to think in terms of an obstructive jaundice. So roughly from the history, you need to when you tell the history and even in your discussion, you need to try to differentiate whether it is a pre-hepatic, hepatic and post-hepatic jaundice with these three predominant findings. And if it is a post-hepatic jaundice, what is the another one more finding you are going to get from the history?
Itching.
Itching, very good. So if there is an associated itching, then it either denotes a post-hepatic jaundice or intrahepatic cholestasis. So these are the two possibilities. So if there is itching, then that is also a very strong pointer towards some kind of obstruction. Either it could be a post-hepatic common bile duct in that pathway obstruction, or it could be an intrahepatic cholestasis. So these two things you need to differentiate. In this case, the urine was not that much colored, but still there was no clay colored stools or anything of that sort. Again, another thing is that if the jaundice is mild jaundice, then you may not still get high colored urine, especially if you are just asking a general question. So you need to ask when he passes the urine when he passes the urine first time in the morning, whether that time it is high colored. So if the jaundice is not very high, or if the bilirubin is not very high, then you may not get high colored urine throughout the day, but rather you are likely to get high colored urine in the early part of the day. So that question also you can ask. So if it is there, you can still consider a hepatic jaundice in this case. So there is ascites and there is jaundice. So predominantly we are thinking in terms of hepatic jaundice. There is no itching, there is no clay colored stools, so we don't think it is necessarily be a post-hepatic jaundice. And since there is a choleric jaundice, even though we don't have the history of early morning high colored urine, which might still point towards hepatic jaundice, pre-hepatic jaundice has also to be considered at this point of time. Then after discussion we can narrow down the symptoms further. And of course, in this particular case, from the history, if we are considering hepatic jaundice as a first possibility, then you need to always ask for, you always see if there are precipitating factors for this, the current abdominal distension and jaundice which the patient has. So if it is a cirrhosis, it is a decompensation. So what exactly is precipitating such a decompensation? So whether there is a decompensation, decompensation can be in the form of ascites, jaundice, or even altered sleep-wake cycle. So you told that altered sleep-wake cycle is not there for the patient. So that is one good thing. So at least the patient is not having features of hepatic encephalopathy. But still, since there is progressive abdominal distension, as well as there is high colored, as well as there is yellowish discoloration of sclera, then you have to still see if there is anything which has precipitated the liver dysfunction which the patient currently had. So what all factors you already asked for?
So there was no history of any drug intake. Any indigenous medications. And there was no, and we could also ask for a travel history.
Okay, travel history.
Another place.
What is the importance of travel history?
Travel history, there could be hepatic infections which are confined to to endemic to the area.
Exactly. So there could be hepatitis A, hepatitis E, malaria, typhoid. All these things can cause an added event to the already compensated liver, which can precipitate a decompensation. I think you already told about, you also mentioned about constipation. So constipation also something which could add on to the precipitate the encephalopathy. So that is also important. So basically these history you need to take, and then finally you have told about the constitutional symptoms. No history of loss of appetite, no history of loss of weight, and no history of evening rise of temperature. So that is also important because ours is a tropical area, and more often than not we tend to see tuberculosis of the abdomen. So tuberculous peritonitis, or even in case of a CLD there could be an HCC. precipitating a decompensation. And sometimes there could be malignancy with metastasis to the peritoneum. So whenever we are suspecting a malignancy or a chronic condition like tuberculosis, then you have to ask specifically for the constitutional symptoms like loss of weight, loss of appetite, and evening rise of temperature. If it is there, on top of the, your first differential might be CLD with portal hypertension with the decompensation, but still you need to consider other possibilities of progressive abdominal distension, such as malignancy with peritoneal metastasis or tuberculous peritonitis. So constitutional symptom is also important. And one part in the history which you have not told is that, like if it is a long case, if it is a short case, that is fine, but if it is a long case, there has to be something called a review of the system. You briefly mentioned that there is no chest pain, there is no fluid in the no breathlessness. Otherwise, you have to just briefly mention and touch upon every system. Okay, because sometimes the patient can have chronic cough with progressive abdominal distension, which could be a pointer that the patient might have a tuberculosis with tuberculous peritonitis. Okay, or there could be, for example, if it is a female patient, there could be joint pain, morning stiffness associated with the progressive abdominal distension, which might be pointing towards an autoimmune cause of hepatitis with serositis, and which is presenting as joint pain. Okay. So you have to briefly mention no history of joint pain, no history of morning stiffness, just to rule out the musculoskeletal system, no history of dysuria, urgency, frequency, nocturia. So some of the symptoms of the genitourinary, and no chest pain, angina, just to rule out any cardiac conditions, because there are certain cardiac conditions like endomyocardial fibrosis, constrictive pericarditis, which can present as progressive abdominal distension. So you have to also have that idea that progressive abdominal distension, even if it is ascites, it is not just pertinent to the liver. It could even mean cardiac conditions. So you have to ask few conditions related to cardiac, and then as I told, chronic cough, mucoid sputum, hemoptysis, tuberculosis with tuberculous peritonitis. So just to know that you have touched upon and thought about whole system and various combinations and permutations of the system. And sometimes there could be some hypercoagulable state which would have precipitated the progressive abdominal distension. And if that is the case, there could be even stroke, isn't it? So you can ask for the history of any weakness of one side of the body, difficulty in chewing, difficulty in swallowing. So a few negative history pertinent to each and every system you have to tell as part of the history, so that when you discuss the history, you can try and convey to the examiner that you have thought about all these possibilities. And since there was no other systemic issues, whatever issue the patient is having is currently related to the hepatic. Of course, you want to rule out the prehepatic, but then because of the progressive abdominal distension, along with the progressive abdominal distension cannot be explained by a prehepatic cause. So you are thinking more in terms of hepatic. And I would definitely tell you that it would be better if you could just tell that there is a high colored urine in the morning. If you could convey that point, then it will be easier for you to discuss with the examiner, and you can tell that it is more likely to be a hepatic jaundice than a prehepatic and post-hepatic. And the precipitating factors, you could not specifically get a precipitating factor, and maybe constipation or whatever precipitating factor if you could get, then you can tell that that is the precipitating factor. The importance is that once you know the precipitating factor, then you can target the precipitating factor, and then you can once the precipitating factor has been removed, then the recurrence of the hepatic encephalopathy or the worsening can be arrested. So that is the whole idea. Then blood transfusion and all, I think you will be coming on past history, right? Personal history or something.
Yes, blood transfusion.
Okay.
In the past history. Moving on to past history, in 2020, he was diagnosed with fatty liver on a routine checkup. In 2022, cirrhosis was confirmed by another checkup, and there was history of 2 episodes of fluid tapping. There were no history of any blood transfusions also. So that's it in the past history.
Okay, so importance of blood transfusion. So whenever you are having a CLD case, definitely mention history of travel as well as history of blood transfusion in the past history, or wherever you would like to mention it. Why importance?
So hepatitis.
Yeah, hepatitis B, hepatitis C.
C could be transmitted.
Travel and food outside from intake, hepatitis A, hepatitis C. Blood transfusion, hepatitis B, hepatitis C.
Moving on to family history, there was no family history of liver disease. And there were also no routine medications. There was no allergies associated with the patient. Moving on to personal history, there was there was normal sleep reported, normal appetite with normal bowel and bladder habits. He consumed alcohol since 1985 which was the quantity was specified to be 4 to 5 pegs daily, but it was irregular. He also did not report to be smoking. No smoking was reported. That's all in the process.
So this is also something very important, because in this particular patient you didn't get any precipitating factor. So whether there was any binge of alcoholism prior to the current event, those kind of things you can specifically mention. So if that is what it is, then we have to address that, right?
Okay. So moving on to general examination. In general examination, the patient is comfortable and an IV line was there on the left side. The patient is alert, conscious, oriented to time, place and person. Moving on to vitals, pulse was 76 per minute. It was regular, a regular rhythm, normal volume and normal condition of the vessel wall. There was no radial or radiofemoral delay. Peripheral pulses were felt. Respiratory rate was 19 per minute and it was abdominal thoracic. Temperature was 96 degrees Fahrenheit, afebrile. The BP was 124 over 80 millimeters of mercury taken from the right upper limb in the supine position using the adult cuff size. There was no pallor. Icterus was positive. Cyanosis was negative. Clubbing negative. Lymphadenopathy negative. Edema positive.
Okay. So specifically you have to look for lymphadenopathy, because whenever you are getting a GAT system, in your examination mainly you can have two track. One is the CLD, portal hypertension, ascites. One is that kind of track. Another is hepatomegaly, splenomegaly with lymphadenopathy. That is more like a hematological malignancy track. So these are two different tracks. So definitely specifically look for lymphadenopathy.
Moving on to head to foot examination.
Maybe I think you can just go come to specifically to the GAT system, because I think we are, so head to foot in GA system, what will you look for?
Head to foot, stigmata of
liver disease. Yeah.
Like loss of hair, no loss of hair, no spider nevi, no gynecomastia, no asterixis, no palmar erythema, no ecchymotic patches on the body, no testicular atrophy.
So in your examination, whenever you are telling, you can start from the top. Look for parotid. So basically I will tell why the patient is getting the stigmata of liver disease. Basically because there is increased peripheral conversion of testosterone or androgen to estradiol or estrogen. So it's like 4 times more estrogen in the body of the patients with cirrhosis, because of which you are getting the gynecomastia and hair loss and those kind of things. So basically you start from the top, parotidomegaly, there will be hair loss and there will be gynecomastia. So if the examiner is asking you to examine for the gynecomastia, use the flat of the hand and palpate for the gland. Okay. Gynecomastia will be there. Then spider nevi. Spider nevi, if you have a glass rod, press and then release. So while pressing, it has to be completely, that is how you will differentiate spider nevi from the other nevi. Spider nevi is basically angioproliferation. So once you press with the glass rod, it will be completely gone. And the moment you release, everything will be back blooming. So that's how you will differentiate. So while applying a small pressure, because it is blood vessel, it will get completely crunched. If it was a neve, it would not have happened. So that's how you will differentiate between a spider neve and a normal neve. And then, as you told, ecchymosis you can look. Ecchymosis, what ecchymosis you are actually looking for?
Sir, because if the liver is not able to produce the clotting factors required for coagulation.
Yeah, so that is exactly correct. That is one thing. One ecchymosis is that because there is a APTT, PTINR prolongation along with thrombocytopenia, the patient is at a bit more increased risk of bruising. So there could be bruising here and there. But otherwise you can specifically look for, since you have brought up that topic, you can specifically look for periumbilical ecchymosis. So periumbilical ecchymosis is otherwise known as Cullen's sign. I don't know. Cullen's sign. Have you heard of Cullen's sign? Yeah. So Cullen's sign means usually it happens in necrotizing pancreatitis. So whenever there is an intra-abdominal pathology, depending upon the degree of pathology, there can be certain external manifestation. So periumbilical ecchymosis is known as Cullen's sign. And then there is flank ecchymosis. Flank ecchymosis is known as Gray-Turner's sign. Again, that happens in necrotizing pancreatitis, Gray-Turner's sign. So these two things you can look whenever it is not part of peripheral stigmata, but then since you have brought in the topic of ecchymosis, these are two things which you need to remember in the context of a ecchymosis in the abdominal system. Okay. And then, of course, you can look for testicular atrophy. The normal testicular size is just a bit more than 3 centimeters. So if it is less than that, 3 centimeters in all dimension. Okay. To be very frank, 2.5 into 3 into 4. That is the normal testicular size. So if you can just remember as just more than 3 centimeters. If it is less than that, then you can consider it as a testicular atrophy. Then, of course, you look for the Dupuytren's contracture. Dupuytren's contracture is the contracture of the palmar fascia, and usually there will be flexion of the last two digits, that is the little finger as well as the ring finger. So there will be flexion of these two digits, and you also palpate to see if the palmar fascia is contracted. You will most of the time will be able to see, and then you look for the palmar erythema. Okay, so these are some of the peripheral stigmata of the liver disease which you have to look for. So you can start with, if you are getting a GAT system, head to foot examination. After completing the PIC code, you can tell the peripheral stigmata of the liver disease were present or absent depending upon the situation. But you mention all the peripheral stigmata of liver disease. That will give you a heads up to the examination port. Okay, then you will look at the oral cavity, upper like upper GA system. Then you will go to the lower GA. Okay, so lower GA. Let's start with the lower GA.
On inspection, the abdomen was grossly distended, flanks were full, and there were no visible peristalsis. Umbilicus was everted. There were no visible veins, scars, or sinuses. Hernial orifices were checked and found to be normal. Inspection is done. Moving on to palpation.
Okay, so inspection also you start, as you rightly pointed out, scar, sinus, dilated veins, all these things you can look, and then visible pulsation, peristalsis. If there is peristalsis, intestinal obstruction. Visible pulsations means you have to further characterize the pulsation. What kind of pulsation? Then ecchymosis, we already described the ecchymosis. Then always remember to look at the hernial orifices. Don't forget, because that is in examination, that is what most of the time I have seen. Most of the time the students, when they present, they will ignore the hernial orifices. So hernial orifices and external genitalia, at least make a passing comment in the inspection, because sometimes you will miss gross hydrocele. Yeah. Sometimes you may just miss hydrocele. So which is kind of give the examiner a hint that you are not very interested in examining the patient. So that should not happen, especially because there is whenever there is gross ascites, there is always a possibility of hydrocele. So that you have to always remember. So always look at the external genitalia as well as the hernial orifices. And if you are seeing, of course, look at the umbilicus, see if it is inverted, everted, and if there is some kind of mass kind of structure. If it is there, you confirm during the palpation. I think we will come to the umbilicus and periumbilical mass during the palpation. And whenever you are seeing a vein, so what you need to do is that whenever you are seeing a vein, make the patient stand up. And then what you need to do is that if, for example, if there is a dilated vein, whenever there is a dilated vein, you need to try and figure out the direction of the flow of the vein. The blood in the vein. Okay, so if there is a column of vein, what you need to do is that you empty out the column of the vein, and then you release the lower digit to see if the blood is gushing from bottom to top, and then you release from the bottom finger and see if the blood is gushing out from top to bottom. And depending upon the direction which the blood is gushing out, you will be able to see if it is you will be able to see and make out if it is a inferior vena cava obstruction. In which case the blood, whenever you release the finger, there will be gushing of blood from bottom to top, or if it is a superior vena cava obstruction. So the blood has to eventually reach the heart. So that there will be reversal of flow. So that is the second thing. Make the patient stand, and then you empty out the column of the vein, and then you release finger one by one and see the direction of the flow of the vein. So if there is a if your patient has a dilated vein, definitely in your examination, the examiner is going to ask you what is the direction of the flow. Okay. Then. Okay, so that is regarding the inspection portion, and now let's move to the palpation.
Moving on to superficial palpation, there was no local rise in temperature or tenderness. There was no guarding or rigidity present. So moving on to deep palpation.
So superficial palpation, the periumbilical nodules as well as the hernial orifices you can palpate one more time. Okay. So periumbilical nodule, if it is there, what does that mean? That is known as Sister Mary Joseph's nodule. Have you heard of Sister Mary Joseph's nodule? So that is actually if there is a intra-malignancy and malignancy deposits to the umbilical thing, then you will get that hard structure called Sister Mary Joseph nodule. So it indicates malignancy with the metastasis to the periumbilical portion. Okay, so that you have to specifically see.
So moving on to deep palpation. The liver was palpated and the lower border was felt just below the right cartilage, right costal cartilage.
Yeah. So I will just show you in your examination how you need to palpate for the liver. Okay. So if there is gross ascites, then there is no way you can go with classical palpation. You have to do something called tapping palpation. Where you will try to displace the fluid, and then you will So once the fluid is displaced, the only solid structure which is going to remain is the liver in this particular case. So you displace with 2 taps, you displace the fluid, and then you see if the liver is getting touched. Okay, and you slowly move up and see if the liver is getting, if the liver is making contact with your radial part of the hand. Okay, but if the ascites is not that much, if it is a minimal ascites or even if it is a moderate ascites, you will still be able to palpate the liver. In which case, few things. One, your plane has to be in the same plane as that of the patient. Okay, and then your hand has to be flexed at the level of elbow, and your wrist has to be in the same plane as that of the forearm. So this is the plane. Understood? You are kind of flexed at your hip region, elbow is flexed, and forearm as well as the hand in the same plane. And then using the radial aspect of the hand, you try to put a gentle pressure, and then you ask the patient to inspire. When the patient inspire, diaphragm will come down, and the liver border will touch your radial aspect of the finger. If not touching, then when the patient expires, you go up. Again ask the patient to inspire, and all the while you look at the position. My hands are parallel to that of the costal margin. Exactly. So that's how you will go up. And if you are getting the liver surface, then you immediately move to palpate for the left lobe of the liver, because in most of the time, in case of cirrhosis of liver in the epigastric region, sometimes in case of cirrhosis of liver, the right lobe of the liver will be shrunken, and what you are going to get is the left lobe of the liver. So in the epigastric area, you palpate again. Even if you are not getting a right lobe of liver, you are more likely to get a left lobe of liver. So if the right lobe of liver is not palpable and left lobe of liver is palpable, then that is also a feature suggestive of cirrhosis. So you can again tell that. And once you are getting the liver border, then you can try and palpate the surface of the liver. And also you see for the tenderness. If there is tenderness, then that indicates an acute onset enlargement of the liver with some stretching of the capsule, which can happen in Budd-Chiari syndrome, or which can happen in acute congestive cardiac failure. Okay, hepatic vein thrombosis. In these kind of situations, there might be acute congestion of the liver, causing some kind of tenderness. This is the setting of CLD ascites in that kind of context. Even otherwise, for example, acute hepatitis, typhoid fever, malaria, where there is acute liver enlargement, you can still get tenderness. So whether there is tenderness or not, and then you palpate for the surface to palpate for any kind of irregularities, and look for the consistency, firm inconsistency, hard inconsistency. Depending upon that, there might be so many other possibilities, which I think you can read up. Okay. Then what about spleen? This is another thing, examination. If there is a spleen, then the examiner would definitely like you to see if you know the techniques to palpate for the spleen. Do you know how to palpate for the spleen?
Diagonally.
Yeah, from the right iliac fossa you start, because spleen actually the axis of enlargement of the spleen is towards the right iliac fossa. You start from the right iliac fossa, you move up, just like you palpated for the liver, you move up and see, because you have to start from the right iliac fossa, because sometimes the spleen might be so big, especially in case of chronic myeloid leukemia or chronic CALAS or chronic malaria. In those kind of situations, the spleen can be that big. So if you are starting somewhere from the left side, you might just miss it. So that's why it is always advisable to start from the right iliac fossa and then move to in the direction of the umbilicus towards the left costal margin. Okay, so if there is a splenic enlargement, you will not miss it. Sure. And once you get the spleen border, then you double confirm that whatever you are getting is spleen only by palpating for the splenic notch. That is very important. Splenic notch, in that left border, in that edge, you will get a notch while palpating, usually in the middle portion. So that is a splenic notch. And again, you palpate the surface and see, and look for the consistency as well. But majority of the time, you are not going to encounter a massive splenomegaly. Majority of the time, you are going to get a mild splenomegaly. So you should know other techniques of palpating for the mild splenomegaly. Okay, so one common technique is that with your left hand, your left hand, you try to apply force so that the whole rib cage as well as the spleen will just move a bit anteriorly, and then you use the same technique with the tip of the finger. You try to palpate for the spleen. Ask the patient to make a deep inspiration and deep expiration. You slowly move in and see if you can get a tip of the finger. If that is also not possible, then the third thing which you need to do is that you stand on the left side of the patient, and then using the left hand you try to hook on the left costal margin. Okay, and you ask the patient to take a deep breath. So all the other two techniques, if it is failing to demonstrate the presence of a spleen, and if you still think that there could be a spleen, then this is the hooking method. You ask the patient to take a deep breath. So because via hooking, your fingers are just beneath the costal margin. So even if there is a mildest splenomegaly, a clinically examinable mildest splenomegaly, you will be able to palpate the spleen. Okay, so these are the 3 techniques. In case in the exam, if examiner is asking you to palpate for spleen or liver, these are the techniques you need to do. Okay.
So, moving on to kidney, the kidneys also, the renal angle tenderness has to be checked for, but it was not, there was no renal angle tenderness.
And ballotability.
Moving on to percussion, the liver dullness was felt in the 5th intercostal space. Tidal percussion was done and the dullness moved down in inspiration to differentiate between other pathologies. Trob space percussion was done for spleen and it was found to be resonant. Shifting dullness was found to be positive and fluid thrill was negative.
Yeah. So shifting dullness is another thing which you need to be very thorough. You start from the epigastric area, you palpate, you percuss out, and you reach somewhere around the area of umbilicus, just below the umbilicus, where the maximum resonance you are hearing. Once you hear the resonance, you just shift the plane of the fingers and then you start percussing out towards the flank. And whenever you are getting the dullness, you stop there. Now the assumption is that the dullness is due to the fluid. So now you need to ensure that the assumption is correct. So if it is due to the fluid, abdomen, peritoneum, there is no other sections. It is just a single cavity. So you ask the patient to turn to the other side. So the fluid as well as the abdominal content will shift to the other side, and fluid will go down, and the intestine and everything will float. Okay. So now wherever you have got the dullness, that actually has moved to the other side. So you are supposed to get a resonant note. So you see if you are getting a resonant note. So if you are getting a resonant note, you percuss out and see if there is dullness. And I think most of the time that is enough. But sometimes if you again want to confirm, you can confirm again. Ask the patient to come back to the supine position and then just palpate one more time and ensure that the dullness has shifted. Otherwise, you can stop right here. That is also kind of fine. So this is the shifting dullness. But when the fluid is more, you will get something called
fluid thrill.
Yeah, you ask the patient to use the finger to whatever excess air or whatever excess space, we don't want that. So we want it to be a just big space with full of fluid. Then only you are going to get fluid thrill. So you ask the patient to cause some kind of indentation so that the space is kind of narrowed, and then can you place the finger? Okay, yeah, you can place the finger like that and
flick the abdomen like this.
Yeah, flick the abdomen.
Feel the pulsation.
Yeah, flick the abdomen. There will be some kind of oscillation, and that oscillation is what you are going to feel. And that oscillation is not happening via the surface because the surface is indented using your finger. So the fluid oscillation is coming, and you are feeling that oscillation in the other hand. So that is the logic of fluid thrill.
So, moving on to auscultation. Vowel sounds could not be appreciated. There was no venous hum or arterial bruit present.
Okay. You palpate all the areas: lumbar area, iliac fossa, right iliac fossa, left iliac fossa, left lumbar area, hypochondrial area, hypogastric area, epigastric area. So all these areas you palpate for any kind of tenderness or masses. Okay, and then you go for the auscultation. Okay.
The vowel sounds, venous hum and arterial bruit.
Okay, so in while auscultating, of course, you can auscultate for vowel sounds, and then you have to auscultate for arterial bruit. So arterial bruit, one arterial bruit you have to specifically auscultate for is renal bruit. This is your umbilicus. So just 3 cm lateral to the umbilicus and maybe a bit upper. 3 cm upper and lateral to the umbilicus. You put some pressure and see if you are hearing some kind of arterial bruit. So that is something. And whenever there is some engorged veins around the umbilicus, you try to do a superficial auscultation. If there is a superficial auscultation, sometimes you can hear something called venous hum. Especially in case of severe portal hypertension, there will be opening up of umbilical as well as paraumbilical veins, and that is known as Curvelier-Baumgarten murmur. Okay, so that is again a venous hum, not an arterial bruit. So venous hum you can auscultate if there is paraumbilical veins or periumbilical veins. Then look for arterial bruit and aortic bruit as well as in the epigastric area. Bowel sounds as well.
Bowel sound. So rectal examination was not done and the external genitalia was not checked.
Essentially, you have to check. Okay, per rectal examination. Okay, it depends.
Moving on to summary. Say the 60-year-old gentleman Sri Kumar, hailing from Ernakulam, presented with 1 month history of abdominal distension, jaundice, pedal edema, not associated with symptoms of obstructive jaundice, and there were no symptoms of hepatic encephalopathy, variceal bleeding, or any hemorrhoids. Cardiac causes were ruled out. On examination, he is icteric. Pedal edema was positive. Abdominal was grossly distended with shifting dullness positive. Moving on to provisional diagnosis.
Yeah, provisional diagnosis.
It's a decompensated chronic liver disease, probably due to alcoholic etiology, with portal hypertension, not in hepatic encephalopathy.
Very good. So always summarize the history. Always tell the full diagnosis, like chronic liver disease, decompensated or not, probable etiology, if there is any precipitating factors or not, and then if there is complications, if there are complications like hepatic encephalopathy. So this much you need to tell. So that will complete the GI examination. So if you are not getting, one more thing I just want to add is that if you are not getting a predominant or dominant cause of decompensation, then you have to always consider something like malignancy, hepatocellular carcinoma, or if it is acute onset abdominal distension, you have to consider something like Budd-Chiari, or even spontaneous bacterial peritonitis. Okay, so maybe you can add one more sentence. No, not suggestive, nothing to suggest a spontaneous bacterial peritonitis, like abdominal tenderness or those kind of things. So that is also will add to the total history. Total diagnosis. Okay, so at least you need to tell whatever you have said regarding the diagnosis part. So that will summarize the whole GI system which we have discussed. Thank you.
Thank you, sir.